Could you please unmute?
Yeah, I've unmuted it. But sharing of screen is, I'm not able to do that. That's what I'm trying to see.
Ma'am, your screen is visible now, ma'am.
Yeah, my screen is visible. Yes, Aditya. Actually, the thing is, I'm not able to share my presentation.
Ma'am, actually, in the presentation, the desktop learning, you can share from there, ma'am.
Yeah, I have in my desktop actually.
Yeah. Then we can do like that, ma'am.
Okay, I've just opened my this one. So where can I share it? It is there in my desktop actually.
And just go to the home screen and will be visible in the desktop.
Oh, okay. Wait, just I'll do it. I'll open the PPT now. Yeah, I've made it the desktop now, but it is. Aditya, from where shall I get this PPT from? I've minimized and kept in my desktop.
Ma'am, just go to the home screen, ma'am.
Yeah,
Your
home screen.
mobile's home screen.
Yeah. The folder is there in the desktop already. Okay.
Your home screen is not visible. Actually, the Google Meet screen is visible, ma'am.
Okay, home screen, how it has to be visible? How I have to make it visible?
Just press the home button, ma'am.
Where is that home button here? Where is the home button here?
The main home button, is it not visible for you, ma'am?
Yeah, the home button is here. Which home? The Google Meet's home button it is? Google Meet or home button?
Yes, ma'am. Yes, ma'am.
Okay. See, I've opened in my mobile also actually. What shall I do now?
உங்களோட டெஸ்க்டாப்ல இருந்து நீங்க ஷேர் பண்ணலாம் மேம். ஜஸ்ட் லைக் ஒரு ஆப்ல இருந்து எப்படி நம்ம வெளியே ஹோம் ஸ்கிரீன் போவோமோ அந்த இது பேக்ரவுண்ட்ல இந்த ஆப் ரன் ஆகும் மேம். So no issues for that, ma'am.
சரிப்பா. இப்போ நான் இதை மினிமைஸ் பண்ணிட்டா?
Yes, just minimize பண்ணிருங்க மேம்.
I'm minimizing it and I'm just putting it on. Let us see whether it is working out. Now I opened it already in my desktop by minimizing it. இப்போ எந்தில் ஃபுல் ஸ்க்ரீன் காட்டுது என்னோட டெஸ்க்டாப்ல.
ஸ்டில் இங்க கூகுள் மீட்டோட ஸ்கிரீன் காட்டுது மேம்.
ஓகே, சாரி. I'll just do the share now. Okay, you can share it. I'll just say next, then we can put it up if at all it's working.
Okay, fine, ma'am. I'll do it, ma'am. Praveen sir, can we start by sharp 5, sir?
Yes, I start by 5.
Okay, fine, sir.
Can I use the chat box, Aditya? Can I use the chat box there then?
Yeah, ma'am, you can use it, ma'am.
Okay. So still I'm wondering like how to bring this home screen into the.
Ma'am, your home screen is now visible. Just now it was visible, ma'am.
Just now, huh?
Yeah, ma'am.
Oh,
The same
great.
process, ma'am.
No, I just, now it is visible?
No, ma'am.
No? Just now I actually missed off that screen. Wait. Let me see. Yes. Deepo? Now it's not visible?
Ma'am, no, ma'am.
It's okay, Aditya, no problem. I'll just continue with yours only because I just don't want to waste the time. Another 4 minutes
Oh,
is there. Within that, if I try to get, I'll do it. Otherwise, not an issue.
okay, done, ma'am. Done. I mean, shall we start the session?
Yeah, yeah.
Hello, ma'am. Good evening
Hello.
and a very warm welcome to all. I'm Hamida Mustafa, doing 3 final year MBBS from Government Tiruvarur Medical College, State Coordinator of SNO, and the in charge for Dexterity. SNO has been conducting events the past week. through Adrenergix'22. I feel really elated to see medical students from across the nation have joined this workshop on the topic A Primer to ECG for Medical Students. I feel honored to introduce the speaker for today's session, Dr. Nirupa Ma'am, MBBS MD Physiology. Now she is a professor at Annapurna Medical College and Hospital, Salem. She has 11 years of experience and has received 4 gold medals for the best paper in the APT COE. She has published 12 research articles in national and international journals. We welcome you, Ma'am. Without any further delay, I would like to hand over the session to Dr. Nirupa Ma'am.
Thank you, Amida, for that nice introduction. So, Aditya Pandian, you can share the PPT from your side because I'm not able to do from this side. We'll just do it from yours.
Sure, ma'am. I'll do it now, ma'am.
Okay, shall we start now? So, today they have given me a small topic about the physiological. I've started it, right, Pandian? Is somebody there guiding me to say next? Yes. Okay. Okay. Now, we'll be seeing just a physiological basis of an ECG. So, ECG is a vast ocean, like where I'm a physiologist, so I'm not going to go very deep in medicine and make you a great person who can see a ECG and diagnose it. But I'm going to definitely create an interest in you in learning ECG in your upcoming classes. After this session, I'm very sure that you people will definitely go and go back to ECG and read what it is. That is what I feel now. Like so the next. Okay, so just today it is a primer section and we are just going to beginners and learners where we are going to learn what is ECG. Next. So today there'll be many things which I think I'll learn from you people and you also can learn from me. So generally I put so many questions during my classes to the students. So at the end, even I land up in learning few things from them. So this is a very favorite quote of mine of Albert Einstein, who says that I never teach my pupils. I only provide the condition in which they can learn. Next. Okay. Next. So now I'll just take up the chat box from all of the students. I have seen some 28 upcoming medicine people have joined. What are the next? What are the possible diagnoses by using an ECG? What are the diagnoses possible by using an ECG? So I'm just expecting the answers in the chat box from you all. Is Niranjana Davis has joined just now? Yes, you can also give your answer now. What are the diagnoses possible by using an electrocardiograph? When you have a graph in your hand. Okay, arrhythmias, very good. Mahalakshmi has answered. Myocardial infarction, very good. Infarction, yes. So all 29 responses, we can get some 29 responses from everybody. That is what I think. Whatever, even it can be a repetition, not a problem. Fibrillation, infarction, yes. Stenosis, good. Yes. Next. Okay, next slide. Cardiac failure, very good. Heart blocks, very, very, very good. Okay. Next. Next slide, please. Okay. So these are the list which we can get through an electrocardiogram. The anatomical orientation of the heart. You can see whether it is a dextrocardia, depending upon the direction of your waist, and variety of disturbance of the rhythm and conductions. Like that is what they were telling your friends were talking about the heart blocks. How is the rhythm? Rhythm and each beat and every beat has one rhythm. It beats in a rhythm, right? As a youngsters, you people dance for a beat and that happens in a rhythm, right? The conduction which it happens. And ischemia, infarction, as they mentioned already, and particularly even your electrolyte disturbances like your sodium, potassium, and all these concentrations can be done. And when the patient is on some drugs, like we can say the digitalis will produce a change, which will assume that there is a pathology. That doesn't happen. So that is normally because of a digitalis drug which he is taking, and also your pacemaker activity. So these are the list in which you can get your, with a single ECG and a paper, which you can land up in having so many diagnoses in your hands. Next. Okay. Okay. What is the basis of ECG recording? What do you feel? What do you feel from this? What is the basis of doing it? What is the base of it? Body is a, I like somebody to complete my sentence. Body is a good. Body is a good, which we read from even our schools. Yeah, very good. It is a good conductor. Next slide, please. The body. Next slide, please. I think I put up many next. Next slide, please. Next, please. Next slide. Okay, you can just put up the next three, four points also. So the body is a volume conductor. Okay, enough. The body fluids are good conductor of electricity because it has, you would have read your ECF and ICF compartments. All your ECF and ICF, what is the major compartment? What is the major component of ECF? So just brushing up your knowledge, what is the major component of your ECF? Which is the major ions present in your ECF? It is like your seawater, which is your sodium and chloride. So it has got some ionic distribution. Velia will have more sodium. Ulla pathina nariya potassium will be there. So all these ions will be distributed. The body acts as a, because of these positive and negative ions. The major anion being your chloride and your proteins which are present in your body, and everything are positive and negative charges. You will get an electrical variation and a dipole is created. A small of this current which is created in the heart will be spreading all over the heart, which will be picked up by us as electrocardiograph. Because the fluid, the base which is running in our body is a good conductor of electricity with lot of electrodes dispersed in them. The next. Okay, this is the basis there. We have more of sodium, chlorides and ions. And when we keep a positive and negative and connected to a battery, you get a recording, definitely, because we have charged particle in the solution in which the heart is being immersed and kept. So we have the charged ions inside and outside of your cardiomyocytes. Next. Next slide. Yeah. So this is a person whom we are going to mainly talk, who is the basis of why I'm here now. Is Willem Einthoven, for which the Nobel Prize, and usually the physiologists and the medicine people share a common for Nobel Prize. Usually they share the Nobel Prize. It can be either a physiologist or it can be a medicine person. So in that way, in 1924, for invention of this electrocardiogram, this was a big mission which he first did it, first ECG. Now you have your smartwatches and everything, which has so much come. But next slide, please. So, but the base of ECG, the basis, the principle behind doing an ECG, the last point why which I mentioned there, they still work under the same basic principle and techniques developed by Einthoven. Okay, Einthoven, Willem Einthoven. He's a very interesting person. Using a string galvanometer, he himself made a reference point and he did on his own thing itself. Now, in the next slide, please. Next slide. Okay. Now, this is a very beautifully evolution of ECG. Before the previous slide, yeah. Previous slide. The previous slide. Yeah. The evolution. The first person is the next slide. Sorry for that. Whoever is operating, I'm not able to share from here. Okay, this is the one evolution of this one. So you can see the Einthoven was in the middle of this screen now. Middle of here, the first was Carlo, who did in the frog art, and Waller was the person who did first in the human art. But what he did, he found only two waves. One is A and B waves. Then what happened? This Einthoven modified it, and he did a 3-lead EKG machine. And then further one, the precordial leads, which we call it as V1 to V6, was done by Wilson, and Goldberg did it augmented lymph lead, that is AVR, AVL, and AVF, and all these modifications were done from the Einthoven's period and above. So why did we name this waves as P, Q, R, and S instead of A, B, C, D? The Valor made it AB only, but what this Einthoven did, he said like, no, I don't want AB, CD and all. I'll be doing it with PQRST. So we'll be seeing it. There is a nothing very much interesting story, but just think about it. Why he named it as PQRST instead of ABCDE and all? Because he would have started with that. Yeah, there is some small reason behind it, which we'll be seeing it. So what is that AHA standardized? Now we are having a 12 lead ECG. What is the 12 lead? Can you guess? Everybody would have already read it. We'll just brushing up today. So let it be a brushing up session. What are the 12 leads which you are doing it? We'll just have a small in few seconds. What are the 12 leads, you know? What are the 12 leads of ECG? Yes, come on, SNO students. Where are you? What are the 12 leads of ECG session? Yes, very good. V1 to V6 is a yes, lead 1. I'm just asking my students also to join if possible. Yeah, lead 1, 2, and 3, AVF. Yes, another 2 augmented. One augmented has come, AVF, AVL, and AVR. Very good. Then we'll go for the next slide, please. So the next slide shows about, can any guess like who has got the Nobel Prize for this year, 2022? Yes, it is a Swedish geneticist, Santo Pabo, for his genomes of extinct hominins and human evolution. He is a person who got the Nobel Prize this year, and it was again shared by physiology and medicine together. The next slide, please. Okay. So what is ECG? Wow, what is picked up in the ECG leads? Nothing is, it's only the conducting system of the heart, which you write many times as a short note in your physiology. It is the conducting system of the heart, which you get it as from the SA node to AV node, then you get the bundle branches, then your Purkinje fibers. So all this is recorded same time as your P, Q, R, S, and T waves. So when the cardiac impulses pass from the heart, the electrical current is spreading. When SA node to AV node, when the transmission occurs from SA node to AV node, which chamber is getting depolarized? When SA node makes as a pacemaker and starts there, which chamber get depolarized? Which chamber is getting depolarized? It's the atrium which is getting depolarized. Very good. So it's the atrium which is getting depolarized. And from the AV node, when it is passing through, and there is some pause in the AV node, which is called as AV nodal delay. Why? Because the fibers of AV node itself is the gaps are very wide in that, so they will have a small delay which is happening in the AV nodal tissue. The AV nodal tissue itself will produce very small amount of current, which is hardly being recorded in your ECG. So that AV node, what we record is given in PQ segment, which will be coming up here. And later, what after AV node, you already know that one simple point I wanted to mention here is the current can directly pass from atrium into the ventricle, but that doesn't happen actually. Why? The current can directly pass from atrium to ventricle. It doesn't happen because atrioventricular tissue, which is there, the atrial ventricular tissue, which is there, is already a fibrous bundle. It is a fibrous bundle in which it is already present there. So the AV bundle, which is there, will be okay. The atrioventricular bundle itself is a conducting tissue, which is very much cannot conduct it. So always all the impulse has passed through the AV node, then it has come to the ventricle. The next slide, please. So the important message which we took is only the conducting system which is taken up. So the conducting system itself is now, we saw it is generating some electrical potentials, depolarized. SA node is first depolarized by a potential called as pacemaker potential, and that itself is spreading an impulse all over your atrium, and that is picked up by the electrodes which we place on the surface. So almost all of the heart is getting depolarized in one cardiac cycle. One cardiac cycle, entire of the heart will get depolarized. For the next cardiac cycle, again the heart will get depolarized. And again a new current is being generated each and every time. So the sum of all the electrical activity which is picked up by the atrium, ventricle, and all the bundles and everything will be put up together. It is algebraic sum of the action potential in all your cardiac fibers, which occurs in one single cardiac cycle, or otherwise called as one single heartbeat. Next slide. Does the ECG assess your mechanical or electrical activity? Guess, please. Does it assessing the mechanical activity or electrical activity? It is very obvious question. But why I'm saying is your heart is contracting. Always any tissue in your body, either it may be a muscle, heart, your visceral tissue, anywhere, electrical activity will be preceding your mechanical activity. Only when a tissue is supplied by an electrical activity, it can bring about the contraction of the heart or contraction of the muscle. Whatever it is only the electrical activity which will be recorded and muscular activity will be shown there. Yes, the next slide, please. Next. Okay, ECG does not assess the contractibility. It is recorded. Only the electrical activity is recorded. Next slide, please. Next slide, please. Okay, the previous one. The previous slide, please. Okay, we'll just skip that slide. That is not an important. So definitely all of you must be knowing the difference between electrocardiogram, electrocardiograph, and electrocardiography. Gram is the record which you gram. Gram nale when you have a record. It can be a spirogram, it can be electrocardiogram, it can be an electroencephalogram, whatever gram it is the one which is being the paper which is having in your hand. Graphy is the procedure which you do. You place the leaves, you connected to an electric point and everything, whatever procedure you're doing while you are recording a ECG, we call it as electrocardiography. Electrocardiograph is the instrument which is actually used to measure the electrocardiogram. I don't know whether I'm doing very basic one because I'm a physiologist. I just want to only do the basic one for you and give you only a basic strong information. That is what I'm trying to do. So, and I think this three informations which everybody should know it. A gram, graphy, and a graph. Next. Next slide, please. Yeah, a very important one. Everybody to the next slide. Next. Okay. Everybody must know is you would have seen a graph paper, right? We would have drawn a graph paper in a mathematics. Many would have taken maths till 10th standard. The graph note on that was the most easiest part of the maths which we do always. And everybody will get a 10 marks in a graph paper. And then who all have got 10 marks will also be getting a full marks in your ECG now. So the strip of the graph paper you can see here. You can see there are some 5 small readings here. X-axis is always I insist my own students that anywhere you see a graph, just see what is there in your x-axis, what is there in your y-axis. Okay, so always any graph, it may be, it can be an oxygen hemoglobin dissociation curve to whatever it is. Any graph you see in your life, but see what is, even your cystometrogram, which I'm telling about your urine volume and everything. First see what is there in your x and y axis before you do anything else. So the x-axis is here. The x-axis will be recording the time duration in which it is, and y-axis will be recording the amplitude in millioles. Okay, so is the next slide. Yeah, the next. So amplitude in next, please. Next. Next slide, please. Yeah, this is the speed of the paper. This makes a very important point. Yeah, we'll stay with this. The next, the speed of the paper is very important. If it is 25 millimeters per second, the speed of the paper is 25 millimeters. That is very important. The speed changes and everything is going to change here. And everybody must know this recording here. So once a big box will be corresponding to 0.5 millivolts. Each small box will correspond to 0.2 seconds and one large box will correspond to one small box will correspond to 0.04 seconds and one large box will correspond to 0.2 seconds. We'll stick on only to the large boxes today. We'll not go much into small boxes just by knowing that is in a small box is 0.04. But we'll stick on to large. Each large box in the x-axis will have 0.2 seconds and y-axis will be showing millivolts. How will you calibrate this millivolts there? You will be calibrating it as 10 millivolts is equal to 110. You can see here the millivolts. 1 millivolt is equal to 10 millimeter. So 10 millimeters means it is 2 large boxes. So 2 large boxes in the y-axis will be giving you a 1 millivolt diffraction, which is equivalent to your R wave. The R wave is almost 1 millivolt in height. So whenever you calibrate an ECG paper, the normal ECG will have the calibration of an R wave, which is about approximately 1 millivolt, which is 10 millimeters. So what I sincerely say is it's like a tables. 2 into 5, 10 into 10. Like that, you must know the duration of ECG and the x-axis and y-axis calibration. This is called as calibration, we call it as. So x-axis will have a calibration of 0.2 in 0.2 for one large boxes, and y-axis will have two large boxes will have 1 millivolt. Okay, so next slide, please. Only when you know this, you will be knowing whether it is correct or not. So in this diagram, you can see if the paper speed you have not fixed it to 25, if you are going to fix it to 50 millimeters per second, see the distance between the R wave. Then we can think this to be as, we can think this as a art blocks where they have missed something or any prolongation of RR interval. We may mistaken it for that, but only when the paper is set in 25 millimeter, what all the duration we are going to see in the upcoming slides will be correct. The next slide, please. Okay. In this, you can see your amplitude is fixed to 1 millivolts RR wave. Otherwise, it will become very difficult for us. Next. Okay. Okay. How do you understand an ECG? Understanding ECG, what all you look in a paper, you take an ECG paper, what all you have to look in an ECG paper, you have to look for the rhythm, you have to look for the rate. What is the rate, heart rate, the intervals, and also the polarity. What is the direction of P, Q, R, and S wave? Next slide, please. Next slide. Yeah. Remember, the electrical activity is depending only on the position of the leads. It depends on the position of the leads. If the position of the lead is not placed properly, then the recording which you are going to is not going to get proper. The first one which you have to set properly, we saw is the speed of the paper. Look into every ECG paper down, there will be written the calibration. That is 25 millimeters. 1 millivolts is equal to 10 millimeter. That if you take a ECG paper and see, that calibration marking will be there. If at all they have mentioned it as 5 millimeter is equal to 1 millivolt, then you have to read the ECG accordingly to that. Otherwise, it will become difficult. So what do you mean by a lead? The combination of two electrodes, we call it as lead. What are the electrodes? Next slide, please. Okay. This is the Einthoven's triangle, which we saw. Einthoven's triangle is a triangle where we have a heart at the center. So what does it say that? So it acts as a dipole. The act as a dipole, and some of the potentials of all the three will be at a zero potentials. So you can see here, base of the heart is recorded by lead 1. Lead 1 is between right atrium and left atrium, and the electrode will be pointing towards the left atrium, which is a positive side. And again, you can see the lead 2 is on the which is recording the basal. Again, it is recording the lateral aspect of the heart. It is between the right atrium and left foot or LL, and the lead 3 is between the left atrium, the left arm and the left leg. Left arm, left leg, right arm, left arm, and all these three form in the anti-clockwise direction. So lead 1 is between right arm and left arm, which will read your base of the heart. If you take a lead 1 and if you see any abnormality, then we can say that there is some disturbance in the base of the heart. And now right arm and left foot is lead 2. Why always we read all the ECGs in lead 2? This is the second question which we are going to keep in our mind. The first question is why he named it as PQRS instead ABCD. The second question is why always, the physiology favorite question is draw your ECG in lead 2. They'll say lead 2 is between your right arm and left leg. So it is an anti-clockwise. The lead is 1, 1, 2, and 3. The next slide, please. Okay, lead 1. Okay, we can move on to the next. Okay. So Einthoven's law. Einthoven's law, what does he say? Einthoven's law, the sum of the two electrodes, lead 1 and 3, will be giving the lead 2. We can see this practically very well here. Left arm is connected to positive or negative in lead 1. Chat box, please. Left arm is connected to positive or negative in lead 1. In lead 1, is the left arm positive or negative? Positive, very good. In lead 3, okay, good. Lead 3, left arm is, lead 3, left arm is, okay, lead 3, left arm is negative. So it's getting neutralized almost, and you get a, okay, fine. So the lead 1 and lead 2, positive and negative are getting balanced, and you will be getting, this is an ECG paper which we have taken. Lead 1, you can see the sum of the voltage of lead 1 and lead 3. What is the voltage in lead 1 of R wave? It is 10 millivolt. What is the voltage of lead 3 R wave? It is some 7 millivolts. But what is the height of the R wave in lead 2? It is 17 millivolts. So this is a practical demo. You can take any ECG and read it. So lead 1 and lead 3, if you add the sum of the voltage height between the two one, how do you say it is 10 millivolt? How do you say it is 10 millivolts? Okay, we have to know the calibration again. We'll just move on to it. Next slide, please. Next slide. Okay, so this is the basic one again. Electrodes are just a metal plates applied snugly over the appropriate body parts. There are 12 ECGs. Next slide, please. Next. You have 6 limb leads, which you have already, all of your friends have mentioned. You have 6 limb leads, which is lead 1, lead 2, and lead 3, and 3 augmented limb leads, which are AVR, AVL, and AVF. When AVR is concerned, that is only one exploring electrode with a positive in right arm, AVR, right arm, and AVL is positive electrode in the left arm, and AVF is the positive electrode in the left, which F stands for foot. So these 3 plus your lead 1, lead 2, and lead 3, we call it as limb leads. Because why do you call it as limb leads? We place the electrodes on the limb. Generally, the electrodes are placed on 2 shoulders and your groin region, where the heart is placed at the center. But generally, we don't place it on the shoulders. Where do you place the electrodes? We place it on the forearms. The leads are placed on the right and left forearm and your left foot, and right foot acts as your grounding one. So next slide, please. Next. Am I audible? Next. Yeah. Okay. Bipolar. Why do you call it bipolar? Because it is the electrical difference recorded between 2 poles, lead 1, lead 2, lead 3. There are 2 exploring electrodes there. But unipolar limb leads are AVR, AVL, and AVF, where you have only single exploring electrode, which is in a right arm, one left arm. Other 2 acts as an indifference electrodes. So they are called as unipolar augmented limb leads. And you have a beautiful chest leads, V1, V2, V3, V4, V5, and V6, which is placed in the respective positions, which you can all see, which is non. Why you have so many leads? Or lead, only those 3 which was mentioned by Entho, and that time is enough. 1, 2, and 3. Why do you want in all these things? You have so many leads, some 12 leads are there all over your heart. It's like Big Boss house watching. Your heart is watched all over by the cameras. Like that, it is watching from all direction. The next slide, please. Okay, this is the reason why you have so many leads. Your limb leads, the 6 limb leads which we read as, will record the frontal plane and the vertical plane axis, and the chest leads will be recording your horizontal axis. So the art will be viewed almost in all the direction, your horizontal plane, from above, this side, that side, and everywhere. And we are going to get an input of your, if it is whichever wall is in deficient, infarction is there, we can read. So many leads will give a 360-degree angle view of your heart. Next slide, please. Okay, this is the frontal plane and the horizontal plane. Next. Okay, these are the colors of the leads which you will be seeing in your wards. You can go and see. I'm just not going to brush it up. Only one point I'll say is every lead has its own color. It has got this red, and it's unique for that particular arm only. So left arm means it is only yellow color. The next slide, please. Okay, this is how we recorded. Next slide. Okay, now coming to the waves, I just doesn't go too deep about it. So P wave is the one between the SA node and AV node. Whatever is happening between your SA node and AV node, and the ரெண்டுத்துக்கு இருக்க bond, that bond between your SA node and AV node is recorded as your P wave, which is the atrial depolarization. And what is this PR interval? What is this PR interval? It's all known to you. You have to guess and tell it to me. What is this PR interval? What is happening in this PR interval? It is AV nodal delay. Not only AV nodal delay, there's something else also is happening there. Okay, ventricular filling. Somebody has come up with this. Jay Kumar has come up. Okay. What is happening in that PR interval other than AV nodal delay? Even your bundle branches, your Purkinje fibers are getting excited. Only when they get excited, the ventricular can get depolarized and bring you a complex called as QRS complex. Again here, you can see P the depolarization, it has got a positive wave. Why this ventricular depolarization is bringing up so many positive and negatives together? Q is negative, R is positive, S is negative. Again, okay, these entire together we call QRS is for ventricular depolarization, and T wave is again a ventricular repolarization. What do you find the difference in the T wave? What is the peculiarity you can see in T wave? It is little bit prolonged. What does it indicate? Depolarization of the ventricle is quicker than the repolarization. Repolarization takes time, so the T segment is prolonged, but the QRS depolarization is shorter. Okay, so repolarized T wave, you can see it is prolonged little bit than the QRS duration. The next slide, please. Next slide. Okay, these are the waves and duration. The next. Okay, good. P wave is not more than the previous one. Just the previous one. We'll just have a small brush up of it. Okay, everybody must know this as a table. You must know the duration of P wave. It mustn't be more than one. If it is more than one, we call it as atrial hypertrophy. When the API is hypertrophy, you get the height of the P wave as more. QRS, if you come, it has to be duration must be only less than 0.08. If the duration of QRS is prolonged, what does this indicate? It can be some abnormality in the ventricular repolarization. The same way, only just knowing the duration. See, this diagram is a very beautiful diagram. You can see P wave here. How many big boxes are there in your P wave? For me, it is little blurred here. How many big boxes are there in P wave? It is some. How many large boxes are there in P wave here in blue? How many large boxes are there approximately? How many large boxes are there in P wave? Yes, where are you people? SNOs, come. Where are this? How many large boxes are there in P wave in this particular diagram? How many large boxes are there? You're not able to see. No answers at all. How many large? It's approximately some 3.3 to 4 large boxes are there. Okay. How much one large box duration is? How much is the duration of one large box? I'm just provoking you again. What is the duration of one large box? What is the duration of one large box? 0.2 seconds. So what will be the duration of 4 large boxes? It is approximately 0.8 seconds. So your duration of P wave is 0.8 seconds, which will not shouldn't be more than 1. Okay, more than 1 second. It is not 0.1, it is 1 second there. 0.8 to 1 second. 0.8 to 1 second. The correction will be there. So by knowing your duration of one large boxes, you can easily predict the duration of the P wave, Q wave, everything in your ECG one. The next slide, please. Next slide. The next you can put up the other. Okay. PR interval you should know. PR interval is very important because it shows us the AV conduction time. If there is any AV nodal delay, then this will be delayed. Next. You can put up next 2, 3 will come up. Next also you can put up. QT interval is a one systolic time. Next one. The next also you can put up. Fine. What is the difference between a segment and the interval? Segment is an isoelectric line. You can see here how many segments are there here. ST segment is there. You can see where is the ST segment. It is between the end of the S wave and T wave. So that is an isoelectric line. Again, PR segment. It is between the P and the R. That is a segment. Segment is a one isoelectric line. Always you read a segment as elevation or depression. Particularly all of us know is ST segment. ST segment in infarction, it is elevated and depressed. Both can be seen. Okay, so segments are used. It is an isoelectric line which is seen as deflection or it can be a decline or an elevation or depression. But interval is the duration. The both are different. Segment and interval, you have to know the difference. Next slide, please. Next slide, please. Okay, the next slide. Okay. J point is one which you have to definitely know. J point is a point where there is no electrical activity happening in the art at the end of repolarization. So that J point is elevated. If the J point is above that isoelectric line, then we call as ST segment has been elevated, because J point is the start of ST segment. So when the ST segment is elevated, your J point will be elevated. The next slide. So this slide shows the previous one. The previous one. The previous one. Yeah, you can see the J point is normal in the first one, then next one, the next. Yeah, and the other things you can see, this is a very important J point you must know, because a common infarction diagnosis can be made by the J point. So J point is elevated here, and you can see the elevation can be seen in the subsequent parts anywhere. If the J point is in the same line of the isoelectric line, then you don't get any other thing. And you can see in the ECG also here, the J point is just above your normal recording isoelectric line. If the J point is elevated, automatically your ST segment also gets elevated. The next slide. The next slide. Next slide. Okay, this is a very, very important of the direction. Why do you get the direction of the waves as positive and a negative one? So when you get the direction of the wave, it is a Q wave there. You can see the first one is the P wave. The P wave is due to the, okay, we'll come to this bigger heart with all the vectors together here. So what is the mean axis of the vector? Altogether, all the electrical activity, the direction of the vector will be that orange color one. So whatever depolarization happens in the orange line, then it should be a positive wave. Away from it, it should be a negative wave. So P wave is from SA node to AV node, which is in the same direction of this orange vector. So you get a positive deflection. But what about this Q wave? Q wave is the septal depolarization. That is the intraventricular septum. Always the septum get depolarized from the left side to right side. So you can see this is the that red color arrows which is seen, which is away from the vector. So only you get a Q wave as a negative deflection. And R is again a left ventricular depolarization, which larger waves, because left ventricle musculature is always thicker than the right. So the right must, there'll be a larger amount of vector which is happening. We get a broader R wave. And again, you have an S wave there, because the base of the arc which is getting depolarized last will be in the opposite direction of the vector. So you will be getting a small S wave, which is a negative wave again. In QRS complex itself, we have two negative waves. One is Q due to interseptal depolarization, and one is the basal portion which is getting depolarized. Again, T wave is the repolarization, which is a positive wave. Next slide, please. Okay, the next slide. Okay, this is again a very beautiful diagram. Okay, now talking about this vector again here, the combination of all the vectors. What do you mean by vector? They're always a flow of current in the positive direction, towards the positive direction. So the lead one, always the current flows to the left arm. And in lead 2, always the current flows towards the left foot. And in lead 3, always the current flows towards the left foot, because the left foot is positive. So combined of all these three together, we get a mean QRS axis. Next slide, please. Okay, this is the direction of the vectors and placement of your leads. Yes or no? So what do you get? The mean direction of the vectors. Very importantly, you have to see where is AVR placed, where is AVL placed, and where is AVF placed. Next slide, please. When do you get a positive? When the vector is moving towards the exploring electrode. That is towards the positive electrode. We get a recording of ECG as positive, and if it is away from that exploring electrode, we get it as negative. Now, we have three leads augmented: AVR, AVL, and AVF. Which lead will be negative? Which lead will be negative? The next slide, please. Okay. Which lead will be negative? Very good. AVR, Manoj has answered. The AVR will be in the negative, because it is away from the direction of the vector. You can see AVR is away from the direction of the vector. When you take an ECG and you read, AVR will be in a negative wave. The next slide, please. The next slide. Okay. This is a diagram. AVR, you can see AVR will have a, we can see from first itself, you can see what is that lead one. You can see normal QRS, PQRS complex, and lead 2 also normal PQRS, 3 also. But what is happening to, in 3, you can see there is some biphasic. The R and S wave are all same. But in AVR, you can see the QRS and the T wave all are inverted like that itself. It is an inversion. This is a normal T wave inversion, which you can see in AVR. Even in lead 3, sometimes the T wave is normal, and even in lead V1 and V2. But other than that, when you progress and see AVL, it becomes positive because you are now your mind, when you're reading an ECG, that axis diagram has come into your mind. The AVR is away from it, so you get a negative. AVL and AVF is towards your vector side, so it will have a positive deflection only. And V1, V2, and V3 are in the direction. The previous slide, can you go please? Previous slide. Okay, we can go to the next slide, and I'll be updating you there. Can go to the next slide, please. Yeah, this one is very good diagram, which says that AVR is always a negative. But where is V1 and V2, V3? It is towards here. You can see the V1 is near lead 3. V2 is at AVF. All these we get a biphasic one. Biphasic means both R and S wave will be in the mid position. It will not be a positive deflection. So negative is very clear. AVR is negative. Polarity will be positive from that side waves. You can see AVL, lead 1, lead 2, V4, V6, all this which is towards that vector direction. Okay. And biphasic we can see which is towards this AVR side. AVR side, what all is there towards AVR side? Lead 3, V1 and V2. And V3 also. All these you get a biphasic waves. And rest all you get a positive waves. Next slide, please. Okay, this is what again I said. AVR, you can see here there is an inverted QRS complex and an inverted T wave. Next slide. Okay, you can move on. You can give another 4 to 5 clicks. So you know why it is biphasic? Because the position of the V1 and V2 and V3, all these 3 leads are biphasic leads. Okay, the next slide please. Okay, this is a very important information which I wanted to convey is R by S wave ratio. In lead V1, you can see the size of the R wave is lesser compared to the S wave. But once it keeps on moving away to V6, the R wave becomes taller and taller. This is just because of the position of that in the horizontal and the transverse plane. V1 is more towards the AVR negative side, so you get a deep R wave there. And as it goes towards the V6, towards the vector side, you will be getting a positive wave. So this is called a R by S ratio. But where it is biphasic, where is both R wave and S wave biphasic? Biphasic means half positive, half negative. In which lead it is showing a biphasic response? In which lead it is showing a biphasic response? Yes, very good. It is in the lead V3. Next please. Next please. Yeah, R wave increases in amplitude from V1 to V6. S wave decreases in amplitude from V1 to V6. This is a very, very important finding, clinical finding, which you have to see now. We'll see this is called as, the next slide. This we call it as R wave progression. You can see because of the position of the leads, V1, V2, V3, V4, V5, V6, there'll be a positive, only V5 and V6, we get a normal amount of this one. Okay, and in the middle, I asked you one question. Why do you take always lead through as reference? Because lead 2 is between what? Lead 2 is between which 2 electrodes? Right arm and left leg. So it is in the same direction of the vector. So always the waves there will be in a normal pattern which is happening inside. So always we take lead 2 as a reference. Next slide, please. So this we call it as R wave progression. When the R wave is progressing from V1 to V6 in the pattern like this, and you get a biphasic at V3, it is normal R wave progression. When the R wave doesn't progress properly, see here, the progression is not proper. It is abnormal R wave progression here. So frequently it is happening in myocardial infarction. Next slide. The normal R wave progression, this one. You can see here normal V1 to V6. You can see the slide. V1 it is negative. V2 it is becoming still more negative. And as you go to V5 and V6, the R is becoming positive. Next slide. The normal R wave progression is this one. Poor R wave progression is V1 still in V3 also it is still negative. See that R wave is still negative. Even V4 it is becoming negative. Only in V5 it is becoming biphasic. So the R wave has progressed slowly. It should be biphasic at V3. Next slide, please. Okay, next slide. Okay. What does the P wave indicate? You can just move on fast. We can just move this one fast. Magnitude of P wave is the guide of an electrical activity. What do you see here? Next, please. It's a case of mitral stenosis, where you can see a left atrium is hypertrophied, and in tricuspid stenosis, you can see an abnormal P waves. The P waves are not proper. It is either flattened or it is more. Next slide. You can put the next. What do you see here? What is the finding you get here in QRS? We get a deep Q wave. Next, please. Sorry for that. Okay, deep Q wave, more than 0.2, we can see in myocardial infarction. These are the deep Q waves. Next. Next slide, please. Yeah, you get a tall R waves. You get a tall R waves. Yes, you can put for. Okay. Next slide. Next. Tall R waves is seen in ventricle. Yes, definitely. No, ventricular activity is R wave. When it is hypertrophy, definitely R wave is going to become big. When you know the basic physiology of ECG, everything is going to become easy. Next. Next slide. Yes, next. Okay, this is a bundle branch block where there is no R wave at all here. There is a missed beats there, which is happening. Next. Next slide, please. Next slide. Can we move on to the next slide? Next slide, Aditya. The slide is not moving. Can we move to the next slide, please? Okay, no problem.
Ma'am?
Yeah.
This slide was not visible, ma'am?
No, it was not moving. The slide was still actually.
Just a second. Kindly check it now, ma'am.
Yeah, no problem.
Is it visible now, ma'am?
Yeah, now it's visible. Okay. There's a previous slide, I just think. Okay. We'll move from this one. There's a tall peak Q wave in hyperkalemia.
Just a sec, ma'am. I'll mute myself.
Yeah. Okay. So you must know the axis deviation, which is normal axis deviation when it is between -32 and you get here -32 plus 90. If anywhere here the vector falls, the common vector, we call it as the normal axis deviation. If it is anywhere between -30 to there is some electrodes, we get it as left axis deviation, and the right axis is between plus 90 to 180 here. You get a right axis deviation. This is the intermediate axis or extreme axis deviation, either they call it as. So the very beautiful diagram of this right side one, if you remember, and you'll know the polarities and everything, then it is very, very easy to know the axis deviation. The axis deviation between AVL and AVF, we call it as normal axis deviation. Anywhere beyond that, it becomes left axis because it is a negative, and right axis, it is positive. The next slide, please. Okay, this is the same one. Next slide. Okay, you can just move it on. Next slide. This is a normal one. The next slide, please. Okay, heart rate calculations are very important, which everybody of us would have done in first year. So I'll just make it a fast one. We'll only stick on to large boxes today. That is what I said. How many are large boxes? If you divide it by 300 divided by number of large boxes, you get the heart rate. They will stick on only to the pink one, which is the big middle. If it is 300 divided by this ECG has got 5.4 large boxes. So you divide it by 5.4, you get your heart rate as 55.6. Next slide, please. Next slide, please. So here you have two large boxes. What will be your heart rate? Your heart rate is 300 by two large boxes, which will be 150 beats per minute. Next. Okay, what is sinus tachycardia? You get your heart rate more than 187. There is only 1.6 large boxes here. So when you divide your 300 by 1.6, you get 187 beats per minute. Next slide. You get an anxiety. Next. You can just scroll it fast. Okay, you get in anemia, sinus tachycardia, and heart failures. All these conditions, you get a sinus tachycardia. Next. Your sinus bradycardia is the one again when you get it in your arrhythmias, athletes, your meditation care conditions, your cardiomyopathies, all these conditions you get sinus bradycardia. Next slide, please. Next slide, please. Sinus arrhythmia. This condition you must know when the heart rate is varying with the respiration. Inspiration it is increased and in expiration it is prolonged. That is the normal ECG finding which you have to know when there is a variation with the respiration. Next slide, please. So always when you look into an ECG, you have to look for the calibration and the rate. So rate is 1 over. When you take an ECG, check for the rate of it, whether it is tachycardia or bradycardia. How do you check the rate? You have to check the number of large boxes between RR interval, and 300 divided by the number of RR interval large boxes, you get the rate. Next, coming for rhythm, always observe the rhythm is same between two RR interval. Between the one RR and other RR, whether the gap between the RRs are same all over the ECG. That will give you the rhythm. Next. Okay, why ECG pattern? Nodal blocks. How do you expect it? So AV so the next slide, please. So this is the, you can put up the next slide also. This is a first degree heart block. What do you find here? The PR interval is just prolonged. That means it is only a prolonged ECG. The next, please. In second degree, you have Mobitz 1 and Mobitz 2. In Mobitz type 1, the PR interval will be variable, 2:1, 3:1, which is otherwise called as Venki back. I have put a one more slide for that. And next, please. Next. Okay, in Mobitz type 2, what do you find is the constant PR interval will be there, but there is a variation between 5:6 or 7:6. Like that, variations will be there. Mobitz type 1 and type 2 belong to second degree heart block. When you come to third degree heart block, there will be almost a missed beat itself in the middle. So this one, the next slide. So this you can see, there is a missed beat there, no PRS complex between them. Next, please. Next, please. Okay, this is a SA node block where there is a loss of P wave, and then you have this one. You know what is the physiology behind SA block. When SA node is blocked, what do you get it? You don't get a P wave at all when SA node is blocked. Venki-Bach's phenomena, as we read in the previous two slides, it's a type 1, Mobitz type 1 block, which comes under second degree heart block. It's a very important PG question when they ask. So I put up it as separate. Venki-Bach's phenomena is Mobitz type 1. There is lengthening of the PR interval, and as the beats go on in 3 successive beats, there will be a failure of one impulse to be transmitted. Next slide, please. Okay, what is Wolff-Parkinson wise? There will be aberrant bundle. That is, there will be always the impulse is carried from SA node to AV node. Apart from that, there is one more tissue also called as bundle of Kent, which is doing the extra work. You can see that there is a violet color, maroon color line, which is also carrying the impulse to the AV node. In that condition, what happens? The next slide, please. You get a delta wave, and PR interval will be shortened because atria is giving only one impulse. But what is happening? This bundle is giving one more impulse. So what does ventricle think? The ventricle has to contract fast. So in that condition, the PR interval will be shortened. Next slide, please. So what is the ECG pattern you get in WPW is the PR interval is shortened and you get a delta wave. Next slide, please. Okay, this one you have is again sometimes asked mainly in the PG. What is Lon-Ganong-Levine syndrome? And how do you differentiate between WPW and Lennon? This is one, both are short PR interval. Even in Lon-Ganong, there is one more bundle which is directly taking the impulse from the atria to the ventricle without passing to AV node. But in WPW, it is passing through the AV node and then it is coming. So both are aberrant bundles which are carrying the impulses. But so definitely both in both the places the PR interval is going to be shortened. But in WPW we get a D delta wave, but it is not seen in LON. This is the difference between LON and WPW. Next slide, please. So this art block poem, which I'll put up later. The time is getting late. Another 5 more minutes. I'll just try to rush up. Next slide, please. Okay. Okay, atrial flutter is the one when the heart rate is 250 to 300. That means the atria is breathing in its own rhythm. It is moving in a very fast rhythm. For 3 atrial depolarization, only one ventricle can happen because the AV node cannot carry all the impulse which is produced in the atria. In that condition, you get too many P waves followed by a PQRS. Only one can be ventricular. And again, you have so many P waves and carried on. It happens when it is between 250 to 300. You may get a sawtooth pattern. Next. It happens usually in the valvular prolapse. This is fibrillation, atrial fibrillation. When the heart rate is more than 350, there will be irregular waves where you get it called as F waves. These waves are called as F wave. And for 10 P wave, you can get 1 QRS. So that becomes fibrillation. The next slide, please. Okay, this is the only one slide which I wanted all you students to know very well. So kindly tell me, where is the leads now? If there is inferior wall is affected of the heart, which lead will reflect it? Can you please say? If the inferior view of inferior heart is affected, if inferior infarction, can you see? Which lead can reflect it? Which lead can reflect it? Which all leads can reflect it? If the inferior heart is a problem, which all leads can? Okay, lead 2, lead 3, AVF. Okay. Yes. You can put for the next slide. Next. Okay, it is lead 2, lead 3 and AVF. Very good. Lateral is there means, okay, you can just push on. We can just make it. So if it is lateral, where is lead 1? Lead 1 is a horizontal plane. So lead 1, AVL which is above, AVR, that side of the heart, the above part of the heart, that is a lateral view. AVR, AVL, 1, V and 6. V and 6 are towards the lead 1. So all these will be affected in lateral wall ischemia. Anterior, it is, next, you can just put off, move and go. Anterior, it is V4 and V5. If there is any septal defect, V1 and V2. So if the septum is affected, V1 and V2 is just placed above the septum. So you get a septal defect. In the wall, these are the important PG questions again. Which lead will deflect which view of the heart? And this diagram is a very beautiful diagram. If the right coronary artery is affected, you can, the previous one. If the right coronary artery is affected, you will be getting it in the lead V1 and V2. If it is the other artery, circumflex artery or left anterior artery, this diagram, if you remember, you will know which artery is affected, which lead you will get the changes. So ST segment depression is seen in ischemia. ST segment elevation, you say in infarction. Infarction is when from the subendocardium to epicardium to endocardium, entire area is damaged. The next slide. The next, okay. Epicardium is only the small area is getting affected. Then you get ST segment depression. The next slide. You can see in ECG also. The next slide. Okay. When entire part from epicardium to endocardium is damaged, then you get an elevation. Next slide. So why do you get an elevation and depression? Initially, what happens is the current will be flowing from the infarcted area to away from it. So 3 changes which we expect here is there is a decline in the resting membrane potential in the tissue of the infarcted tissue. When the resting membrane potential becomes more negative, the segment becomes down. So ST is really reflected as elevation in the ECG. The next slide, please. The next slide. Yes, you can. So there is a decline in the resting membrane potential. Usually you can see the dotted lines are shifted down because there is more leaky potassium channels which is happening in the infarcted tissue. So more potassium ions inside the cell is moving out. So inside becomes more negative initially. So there will be a decline in the resting membrane potential. When the resting membrane potential is declined, automatically the ST segment, the second half will look as elevated projection. The next slide, please. The next, please. Okay, this is the last point, which that is electrocardiogram will be reflected when the TQ segment is depressed. It is reflected as ST segment elevation. The next slide. And always you have to observe for three subsequent beats. The next slide. Okay, in anterior wall MI, you get an appearance called a storming appearance. You can see in the ECG, I put an arrow mark, that is storm. This segment will look like a storming. Next slide, please. Again, this is one more ECG which is showing the same storming in anterior wall. The next slide, please. Okay, this one is a nice diagram where the below the green arrow which you have to follow is what are the changes happening in seconds, minutes to months or 2 years. In the months and years, you can see the change is deep Q wave. The old infarct will be presented as deep Q wave, and you can see in the 24 hours T wave inversion and all these changes which has to be seen. If I need to explain all this, it will become, it's a very lengthy one. The only thing is the old infarct will be presenting as a deep Q wave and ST segment elevation, and the opposite leads will be getting ST segment depression. The next slide, please. Okay, also the ECG will reflect you the electrolyte imbalance. In hypokalemia, prolonged, any low, it can be a kalemia, calcemia, or natremia, hyponatremia, everything will be a prolonged interval, and the waves voltage will be very less. Hyper means it will be more. Only important finding is stall T wave, which you get in hyperkalemia, a common MCQ always been asked. And QT prolonged in hypocalcemia. The next. So this is a low voltage complexes. Is the next slide, please. Okay, this is a tall T wave which you can see. This is a low. Okay, you can pass it on. Next slide. Next. These are low voltage. You can see the voltages are very less here. You get in hypothyroid. Next. Hypothyroidism. You get in all hypocalcemia, natremia, COPDs, obesities, and all these electrode plates on surface of the body cannot pick up the electrical activity in the heart. So which will be a low voltage pulse. The next slide, please. So understanding a ECG is you must know the rhythm, whether the interval between that is normal. For that, you must know as a tables, the interval duration, complex, and everything. And intervals, polarity, you have to know. Polarity, I said already, AVR will be always negative, and AVL, AVF, and other leads will have a positive one. Biphasic response can be seen in lead 3, V1, and V2 because they are towards the negative side of the vector. Other things all will biphasic. Now, the waves can be positive or negative. It will be in the mid wave. Next slide, please. Okay, the take home message will be significance of P, QRS, and T wave is interpreted by knowing the duration and amplitude. Unless you know the duration and amplitude, you cannot read an ECG. ST segment, PV, PR segment. Segments are always an isoelectric lines. They are read only for elevation or depression. Next. Intervals are the one which is used to, RR is used for heart rate calculation, QT is used for ventricular performance, PR is for conduction. So intervals are always used for the conducting defects. Segments are used for infarcted tissue defects. Next. Okay, ST segment elevation is seen in MI, and the opposite leads over, if it is anterior one, that particular leads will show elevation, but the opposite leads may show depression. The next slide, please. Tall T wave and hyperkalemia, and low voltage you get in all type of electrolyte low, hyponatremia, calcemia, everything. Next slide. Okay, these are the references, and I'm just finishing it. I don't know whether I rushed or what. I just brushed up the physiology of for you people, everything. The next slide, please. Okay, this is the last slide of mine, and thank you, dear students, for listening. And I thought of joining my students, but I couldn't share the link with them in time. Anyhow, that is over. If I get my presentation, let me see how it is. Anyhow, thank you, Amida. I think I've taken some 4 minutes extra of your time.
That's fine, ma'am. Good evening, everyone. Our Honorable Speaker, Dr. Niruba ma'am, and all the participants. It is such an honor for me to get this opportunity to thank you all on behalf of SNO Tamilnadu. I extend my gratitude to our Honorable Speaker, Dr. Niruba ma'am, to take up time from her busy schedule to grace the event and pass on the knowledge to us. Thank you for inspiring and encouraging us with your words, ma'am. Thank you once again.
Thank you all. Thank you, Aditya, for giving me this opportunity. Thank you all. for the SNO.
Thank you so much, ma'am. Thank you so
Okay.
much.
Okay. Bye bye. Thank you all. I'll just leave the call now. Thank you.
Good evening, sir. Sir, voice is not audible, sir.
Good evening, everyone.
Yeah, sir. It's clearly visible.
How is it audible?
Yeah, sir. It's audible, sir.
Can you share the presentation?
Yeah, sir. Just a minute, sir.
Good evening, sir.
Good evening. Good evening.
Uh,
So I hope all are first year MBBS, right?
no, sir, I don't think so.
Okay.
I feel honored to introduce the speaker for Dexterity 2 on Introduction to Radiology to Medical Students by Dr. Yuva Balakrishnan, MBBS, MD in Radiology and Fellowship in Advanced OG. Now, Sir is working as the head of the department at Radio Diagnosis, Vinayaka Mission Kripananda Varyar Medical College and Hospital, Salem. Sir is the treasurer of Indian Radiological and Imaging Association for Tamil Nadu and Pondicherry. He has received various awards such as Asia Pacific Achiever Award by IIEM, New Delhi, and Diamond of Asia International Award by International Business Council. Thanks for joining us, sir.
Thank you. So it was a very good presentation by the previous speaker, Dr. Nirupa. My presentation is very short and brief presentation. It's just introduction about radiology. Aditya, can you share the PPT?
Yeah, sir. Hamida will share, sir.
Okay.
Just a minute, sir.
So I want everyone to listen to this presentation because it's a very short PPT. I have only 30 slides. The thing is, radiology is the most important field in a medical industry, and for every diseases we have to do scans and diagnostics. Then only you can go for the correct treatment. So you need to know about the what are the scans we have to do and for what conditions we have to do the scans. So we'll have a short introduction about the various scans that is available and we are doing. Okay, we can go to the next slide. Okay. So what is radiology? Radiology is a medical specialty that employs the use of imaging to both diagnose and treat disease visualized within the human body. I have made the presentation in very simple words so that everyone can understand. Radiologists use array of imaging technologies. We use X-ray machines or such other radiation devices like mammo, fluoro, etc. And also we use techniques that do not involve radiation that is harmful to our body. This MRI and ultrasound which doesn't have a harmful radiation. Okay, next slide. We will see on what are the imaging modalities in detail later. So the the father of radiology is considered as Wilhelm Conrad Röntgen. He is a German mechanical engineer and a physicist, born on March 27 or 1845. On November 8th, 1895, he discovered X-rays. It was known as X-rays because he doesn't know what to name it. So it is known as X-rays or Röntgen rays. He was awarded Nobel Prize in Physics in 1901 for discovering the X-rays. Next. So this was the first taken X-ray. This is Röntgen's wife's hand. He took picture using X-rays of his wife Anna Beth's hand. Later, he took a better picture of his friend Albert Von hand at a public lecture. Today, he is considered as the father of diagnostic radiology. So the first thing discovered is X-rays in radio diagnosis. Next. Okay, World Radiology Day. The November 8th, when X-ray was discovered, is considered as World Radiology Day. So it's an annual event promoting the role of medical imaging in modern healthcare. It is, yeah, okay. There are two types in the field of radiology. One is diagnostic and one is therapeutic. Diagnostic radiology is concerned with the use of various imaging modalities to aid the diagnosis of the disease. Therapeutic radiology is now called as radiation oncology, where we use radiation to treat the cancer using, and it is known as radiation therapy. So one is diagnosis and one is therapeutic. Next. Now we are going to see about the diagnostic radiology. Commonly used techniques are X-rays, ultrasound, CT, MRI, and nuclear imaging techniques. So we will see the uses of everything later. Now we'll go to X-rays. Next slide. Okay. X-rays are basically electromagnetic radiation, which are absorption of X-rays of different tissues. You can see an X-ray of left shoulder and shoulder joint. The calcium in the bones absorb X-rays the most, and it is difficult for the X-rays to penetrate the bone. So it is the bones are radio opaque. So the bones are white in color. The fat and other soft tissues will absorb less X-rays, and the X-rays can penetrate more. So it may be look gray in color. Air absorbs the least. So wherever the air is present, it will be black in color. Okay, you are seeing a picture of how they are taking X-ray, and you are seeing a X-ray left shoulder joint. Next slide. Okay, this is one digital X-ray unit where they are taking an X-ray of chest X-ray. It's a posterior anterior view. So this is how they will take the X-ray. This is the X-ray equipment, latest X-ray equipment. Okay, next. Okay, so what are the uses of X-rays? Where whenever there is a fracture, if you suspect there is a fracture or any abdominal distension, you go and take an X-ray. You can see any bowel dilatation or any calculi in the kidney or in gallbladder, or if there is any fracture, you can see in the X-ray. If it is not seen in the X-rays, if you have an abdominal pain, then you have to do ultrasound. So who discovered ultrasound? Ultrasound is discovered by Ian Donald. He was an obstetrician who developed ultrasound diagnostics during the 20th century in Europe. Ultrasound is a medical diagnostic technique that uses sound waves to produce images to see look inside the body. In the early 1900s, we cannot see how the fetus is present inside the womb. For now, we can see everything. So that is the use of ultrasound. So Ian Donald discovered the ultrasound. Next. Okay. So not only for antenatal or to see the fetus, all the structures inside the abdomen we can visualize through ultrasound. Ultrasound is a type of imaging. It uses high frequency sound waves that is not audible to our ear to look at the organs and structures inside the body. We use it to view the heart, that is the echo, blood vessels, that is known as Doppler studies, kidneys, liver, pancreas, gallbladder, and we can see if there is any lymph nodes, if there is any appendicitis, uterus, ovaries, and all the soft tissue organs like breast, thyroid, if any scrotal studies, if there is any injury, everything we can see in the ultrasound. During pregnancy, doctors use ultrasound to view the fetus. Unlike X-rays, ultrasound does not cause any harmful radiation. So we can do multiple times during pregnancy or any abdominal discomfort or any problems. Okay, next. So this is a picture of ultrasound machine, and this is how the ultrasound is taken. So right from your eye to your toe, we can use this ultrasound, which is not a harmful radiation, to visualize the normal thing and if there is any abnormality. If ultrasound could not pick up the disease, then we will move on to CT scan. Okay, next. The CT scan is discovered by Godfrey Hounsfield, a biomedical engineer who has contributed enormously towards the diagnosis of neurological and other disorders by virtue of his invention of computed axial tomography, that is CT scan, for which he has awarded Nobel Prize in 1979. The first clinical CT scan was performed in 1971 using a scanner invented by Sir Godfrey Hounsfield. So he is Sir Hounsfield with his CT scan. You can see the picture. Next slide. Okay, so what are the uses of CT scan? If you are not able to pick up a disease, or if you want to know the extent of the disease and the lesion, you have to take a CT scan. CT, that is known as computed tomography, is a type of imaging. It uses X-ray equipment to make cross-sectional picture of your body. We use CT scans to look for fractures, cancer, blood clots, signs of heart diseases, internal bleeding. Fractures means if there is a fracture in the skull, minute fractures, to look for the orbits, maxilla, mandible, and also the other long bones. We use CT scan in the case of accident and trauma. Cancers, if there is any cancer, we cannot see that in X-ray or ultrasound. We have to look at the extent of the disease and we have to do staging. So for any cancer or a tumor, we have to do a CT scan to that particular organ and to look for the extent of the lesion, and you have to look for any metastasis. So for that we have to do CT scan. Then blood clots. If somebody is injured by any trauma or due to stroke, we have to look at the brain. For that, we have to take a CT scan of head, and we have to look for the brain if there is any hemorrhage or infarct. For that, we have to take a CT scan. Then heart disease. To look at we have to do cardiac CT, and we have to look for the valves and the structures of the heart. Then the same internal bleeding. So in a case of trauma or any other thing, we have to look at the entire body, look for any collection or bleeding. So CT scan is a very essential thing to diagnose all these diseases. We should not take a CT scan for a pregnant woman because it uses X-rays that is harmful for the baby. So other than antenatal women, we can take CT scan for other diseases. Okay, next. So this is the CT scan. That couch where we lie down is couch, and that one is the gantry. That gantry, there will be multiple. There will be X-ray source, and it will be rotating. So there will be a cross section of your body's picture will be taken by the X-rays, and you can see in the monitor. So it uses X-rays. Okay, next. Then we will move on to MRI. Raymond Damadian, the inventor of the first magnetic resonance scanning machine, celebrates his 85th birthday on March 16th. Damadian is a physician, performed the first full body scan of a human being in 1977. So, what are the uses of MRI? MRI is magnetic resonance imaging that uses a magnet. If there is a soft tissue injury or ligament injury, or if you want to look at the nerves, it is very difficult to see in the CT scan. So you have to take MRI scan to rule out the soft tissues and neural components to look for the spine. And if there is any early infarct or hemorrhage that is not picked up in CT, you can take MRI scan. Next. It is not harmful for the body, but if there is any, if your the patient has any implants, steel or metallic implants or pacemaker, they should not take MRI scan, because it may the magnet may have interaction with that thing and it may affect the patient. So MRI uses a large magnet and radio waves to look at the organs and structures inside your body. We use MRI scans to diagnose a variety of conditions from torn ligaments to tumors. MRI are very useful for examining the brain and the spinal cord. Okay, next. So this is the MRI machine. It is almost same like CT machine, but here we have a magnetic field instead of X-ray. So this is the MRI machine. Okay, next. Then
Sir, you are not audible.
now am I audible?
Yes, sir.
Am I audible now?
Yes, sir, you're audible.
Okay. So fluoroscopy is live X-rays. Okay, okay. So this allows the real-time imaging of the structures in motion or augmented with a radio contrast agent. So we can see the structures in live by using the X-rays, but it is very harmful for the patient. But it is for a very short term. Okay, so that is fluoroscopy. And next is the mammography. It is very essential for all the women after above 40 years to screen for the breast carcinoma. It uses the same X-ray techniques, but it is of less radiation. It is used to visualize the anatomy and pathologies of breast. Types screening. It is performed in asymptomatic women more than 35 years of age. Diagnostic is performed in symptomatic women who has any breast complaints like pain or abnormal any discharge from the breast or the skin changes. For those if we take, that is diagnostic. And in women less than 35 years, ultrasound is performed for screening. So if there is asymptomatic and if it is less than 35 years, we can do ultrasound of breast to look for any lesions. Because mammography, it also uses X-rays. It may cause radiation effects. So if we do not want to use mammography, we can use ultrasound of breast. So this is how they'll take a mammography. Then we'll move on to DEXA scans. So nowadays nobody is going in sun, and everyone have a lot of vitamin D deficiency and calcium deficiency. To look for the bone density, we use DEXA scans. It stands for dual energy X-rays absorptiometry. Make use of X-rays to determine the bone mineral density. It is helpful in diagnosis of osteoporosis. So to look for the bone density, we take DEXA scan. So everyone should go in the morning sunlight to get enough of vitamin D. That is very good for your bone density. So we take DEXA scan to look for the density of your bone. Okay, next. Nuclear medicine. So nuclear medicine itself is a separate field that has been separated from the radio diagnosis, but we have to know about that. Nuclear scans use radioactive substance to see structures and functions inside your body. They use a special technology called Adrenergix'22. Nuclear scans can help doctors diagnose lesions in the brain, heart, lungs, thyroid, liver, gallbladder, and bones are commonly evaluated for particular condition using these techniques. So, if you are suspecting a trauma or a carcinoma, if that is not picked by CT or MRI scan, we have to give nuclear radioactive isotopes the radioactive isotopes will be injected into your body. Then it will be scanned, that is known as PET scan or SPECT scan. If there is any activity in thyroid or prostate, then it will be we can diagnose earlierly in a nuclear medicine scan, so that we can detect and treat the cancer or any other diseases in prior, in advance. So that is the use of nuclear medicine. Next slide. So it is also like the same CT scan. We inject the radioactive isotopes, and wherever there is any disease or any abnormality, it will show. Yeah, you are seeing the PET scan images. We are seeing the activity in near the heart, and in the other thing you are seeing in the brain. So by this, we can diagnose the abnormalities earlier. So this is a nuclear medicine PET scan or SPECT scan. Okay, next. So to conclude, a radiologist is a specialist doctor who uses medical imaging such as X-ray, MRI, CT, ultrasound to diagnose and treat human diseases and injuries. So diagnostic imaging provides detailed information about structure or disease-related changes. So earlier the diagnosis, we can save lives. We also use the image guided procedures such as biopsies, FNAC, drainage, targeted injection to directly enable diagnosis and treatment of the patients. A few radiologists also perform more advanced image guided procedures like vascular stenting, aneurysm coiling, and other interventional procedures. Now it is known as interventional radiology. So, radiology is the first line of medical field based on which the treatment is going to be done. So we have to know the diseases and which disease we have to do what scan, and after that, based on that scan report, we are going to treat the patients. Next. So we are going to celebrate the International Day of Radiology on November 8th, and we can celebrate together. Thank you so much. And if any doubts, you can ask. I think now you don't have any doubts.
Yes, sir. I don't think there are any doubts. So it's an absolute delight to have this opportunity to end this evening with a vote of thanks. Our honorable speaker, Dr. Kumaran sir, and all the participants, on behalf of SNO Tamilnadu, I extend a very hearty vote of thanks to our speaker for this excellent session and making this workshop interesting. I would like to thank the entire State Council and my co-in-charge Aditya. Once again, thank you all for your cordial cooperation. Thank you.
Thank you. Thank you, everyone.
Thank you.
Thank you, participants, for the active participation. Tomorrow the workshop will begin and the information should be shared in the group. So kindly follow through it.